Hey everyone, and welcome back to The Explainer. Today we're going to tackle a really complex, honestly fascinating medical anomaly, and we're going to do it exactly like a detective investigating a crime scene. Seriously, we've got suspects, we've got forensic evidence, and we've got a very specific set of clues we need to use to crack the case. But before we get into all that, I want you to picture a kind of terrifying scenario. What happens when your lungs start drowning from the inside? I mean, we usually think of drowning as something that happens in a pool, right, or the ocean. But sometimes the body's internal plumbing just goes horribly wrong and a literal flood happens right inside the chest cavity. So how does this happen? And more importantly, how do doctors figure out who or what caused the leak? Let's dive in and find out. To solve this mystery, we're following a logical roadmap today. We'll start with the healthy pleural space, move on to defining pleural effusion, look at the two types of effusion, and then apply Light's criteria. After that, we'll hit diagnosis and X-ray findings, and finally wrap up with relief and definitive treatment. All right, part one, the healthy pleural space. So step one in any good investigation, establish the baseline. Because before we can understand the crime, we really need to know what a normal, healthy, undisturbed chest cavity looks like. Notice this tiny number, 5 to 15. In a healthy person, the pleural space, which is just that tiny gap between your lungs and your chest wall, contains a highly precise amount of fluid, just 5 to 15 milliliters in each hemithorax, basically each side of your chest. To put that into perspective, that is barely a tablespoon of fluid. It's this absolute Goldilocks baseline, not too much, not too little. It acts as just enough lubrication so your lungs can smoothly expand and contract every single time you take a breath. And here's the kicker. That tiny bit of fluid isn't just sitting there stagnant. It's a highly dynamic, perfectly balanced system. It's constantly being produced mainly by the parietal pleura, which is the membrane lining the chest cavity, but at the exact same time, it's being continuously absorbed and drained away by your lymphatic system. It's kind of like a sink, where the faucet is dripping at the exact same rate the drain is emptying it. Production perfectly equals absorption. Total harmony. Which brings us to part two. Defining pleural effusion. So, what happens when that perfect harmony shatters? This is the inciting incident of our detective story, the moment the balance breaks down. And that brings us to our clinical definition. A pleural effusion is the flood. It is the abnormal accumulation of excess fluid in the pleural space, pushing way past that normal 5 to 15 milliliter threshold we just talked about. Either the drain got clogged or someone turned the faucet on full blast. Now that vital, tiny gap is just filling up with water, physically crushing the lung from the outside and making it incredibly hard for the patient to breathe. Moving right along to part three, two types of effusion. Okay, we've got a flood. Now where's the water actually coming from? We divide our prime suspects into two distinct categories, transudative effusion and exudative effusion. Think of transudative like a systemic plumbing issue. The pipes themselves, they're totally fine, but the pressure in the whole house is completely messed up. This is caused by systemic conditions that alter hydrostatic or oncotic pressures in the body. We're talking things like heart failure pushing fluid backward, or liver cirrhosis messing with the proteins that usually keep fluid trapped inside your blood vessels. On the flip side, exudative effusion is a strictly local issue. The pipes are actually damaged or leaking right at the site. This happens because of local inflammation, infection, or direct pleural damage. The usual suspects here are things like pneumonia, tuberculosis, or even cancer. The local tissue is angry, it's inflamed, and it's literally weeping fluid and proteins directly into the chest cavity. Next up, part four, applying Light's criteria. So you're the doctor. You extract some of this fluid. How do you actually know if it's transudative or exudative? You obviously can't just guess. You need hard forensic evidence. Enter the absolute gold standard for solving this case, Light's criteria. Doctors compare a sample of the lung fluid to the patient's blood serum across three strict rules. Basically, they look at the ratio of pleural to serum protein, the ratio of pleural to serum LDH, and they check if the pleural LDH is greater than 2/3 the upper normal serum limit. And just a quick side note, LDH is an enzyme that signals tissue damage. Now here is the absolute game changer, and they drill this into every med student's head. If even one single criterion is positive, the effusion is exudative. Just one. That means there's too much junk, protein, enzymes leaking out, pointing straight to local damage like an infection. If all three are negative, well then it's just clear fluid being squeezed out by pressure, making it transudative. This handwritten chart here is basically our detective's pinboard. It visually maps out everything we've just covered. You've got the normal baseline at the top left with that tiny 5 to 15 milliliter range. Then you see the clear division of our suspects in the middle. And finally, the mathematical rigidity of Light's criteria right there on the right. Keeping a visual map like this in your mind is absolutely crucial for remembering how all these moving parts connect. All right, part 5, diagnosis and X-ray findings. So we have our lab work, sure. But how do we initially see this crime scene in a living, breathing patient? Well, the primary visual evidence doctors look for is right on a standard chest X-ray. When you look at a healthy X-ray of the lungs, the bottom outer corners, right where the ribs meet the diaphragm, should be these sharp, crisp points. Those are your costophrenic angles. But thanks to gravity, when fluid pools at the bottom of the chest cavity, it completely fills those sharp corners. This creates what doctors call the blunting of the costophrenic angle. Plus, the fluid doesn't just sit perfectly flat. Capillary action makes it creep up the side of the chest wall, creating a really distinct U-shaped curve. That is the classic meniscus sign. You see a blunt angle and a meniscus sign, boom, you know for a fact you're dealing with an effusion. And finally, part 6, relief and definitive treatment. The investigation is over. We've got our culprit. So, how do we actually help the patient? It requires a very logical, two-pronged approach. Step 1 is purely symptomatic relief. The patient feels like they're suffocating because this fluid is literally collapsing their lung. So the immediate action is a procedure called thoracentesis. That's where a needle or tube is carefully inserted into the chest to physically drain that excess fluid and relieve the dyspnea, or shortness of breath. Basically, you gotta drain the swamp first. But just draining the fluid doesn't solve the mystery of why it got there in the first place, right? Which leads us directly to step 2, definitive management, where we finally go after the root cause. And that definitive management? Well, it depends entirely on the culprit we just caught. If Light's criteria pointed us to a transudative effusion caused by heart failure, the treatment is diuretics to help the body flush out that systemic fluid. If it was an exudative effusion caused by a bacterial infection, we're hitting it with antibiotics. Tuberculosis, we use anti-tuberculous therapy. And if the fluid buildup is malignant, caused by cancer, then oncological treatments are the definitive management. You can't just treat the symptom, you absolutely have to arrest the underlying cause to close the case. Which leaves us with a really fascinating question to ponder. If fluid builds up in your lungs, is your heart actually to blame? As we've seen today, the answer is, surprisingly often, yes. The lungs might be the scene of the crime and they might be the ones drowning, but their careful investigation, applying our clinical criteria and looking at the body as one massive connected system, we realize the true culprit is often a systemic failure somewhere else entirely. The fluid? It's just a messenger. Thanks so much for joining me on this deep dive. Keep your curiosity sharp, keep investigating, and I'll catch you on the next explainer.